The views, information, or opinions expressed during AAOA broadcast series are solely those of the individuals involved and do not necessarily represent those of the American Academy of Otolaryngic Allergy, its employees, or members. The AAOA is not responsible and does not verify for accuracy any of the information contained in and assumes no liability for any activities in connection with these broadcasts. The primary purpose of this broadcast series is to educate and inform and does not constitute medical or other professional advice or services. Advertising which is incorporated into, placed in associate with, or targeted toward the content of this product without express approval and acknowledgement of the AAOA is forbidden. These broadcasts are available for private, non-commercial use only and may not be edited or modified from their original form or reproduced for distribution.
Welcome everybody, and thanks to my distinguished panelists here. The goal of today's Zoomcast is really to highlight some of the new CMS coding that is live now. And this I think is going to be a good opportunity to discuss not only the changes, but also how people envision this impacting their practices and if there's been any changes to their workflow. I would like to start just by kind of going around the Zoom panel and just having everybody introduce themselves. For those of you who have not met me before, I'm Jennifer Villwock. I'm one of the otolaryngologists on faculty at the University of Kansas. And then Dr. Stachler.
I am in private practice in Detroit area. I've been in academics for 20 years and went into private practice about 4 years ago. And I do work with residents still. I've been very involved in the AAOA. I do laryngology, I do otolaryngologic allergy general, and I have nothing to disclose.
All right, Dr. Patel?
Yes, I'm Nalin Patel. I'm a private practitioner in the Tampa Bay area. My practice is primarily pediatric otolaryngology. I do have a collaborative position with the University of South Florida, and I work with the residents in otolaryngology there, and just started with them. I've been in private practice for close to 15 years now, and I have nothing to disclose.
Great. Dr. Khalid?
My name is Ayesha Khalid. I'm all the way in the cold in Boston on the East Coast. I am currently hospital employed within an academic health system at Cambridge Hospital. I've been in private practice, academic, hospital employment, all the different models. I do mostly a mix of general otolaryngology, rhinology, and otolaryngic allergy. I would say my practice is 80% rhinology and otolaryngic allergy at this point. And I've been involved with the AAOA, oh my gosh, since I was a resident many, many years ago, and I'm excited to be on this panel. I have only to disclose that I teach a lot of ventures classes at Yale and MIT, and I help with a lot of startups. One that I'm helping with now that I'm on the board of is called Apex Ventures, and that's pretty much it.
Okay, great. And Dr. Connolly?
So I've been in private practice for the past 15 years, split partly in Florida, and then now I'm in Louisiana, just on the greater New Orleans area of that. I subspecialize in sleep medicine as well as otolaryngology allergy and rhinology. Spend about 50% of my time in both fields, and I have nothing to disclose.
Great. So I'd like to start off just by asking, there's been a lot of compliance training that's been required, I think, at every hospital system that reflects some of these changes. And a lot of the guidance coming out is trying to reassure us that either the changes with respect to the RVUs and their value will either be neutral or beneficial for ENTs. I'm curious to hear from you all how you see some of these changes impacting your practice.
It's too soon to know exactly how it's going to impact our practices because I don't think the rules are set yet.
Yeah, I would agree. I mean, I think I'm such an optimist that it was exciting to do something other than prepare for a pandemic with unpreparedness and having yet another discussion on COVID-19. So I will say I was in a meeting today where we were discussing it within surgery and then otolaryngology. And I think that where it may benefit us, we have to see down the road, is that otolaryngology has a lot of in-office complexity, a lot of procedures that we do, a lot of decision-making that happens. We are very much as much office-based, I think, as operating room-based. So I think compared to other surgical specialties, we may benefit if we can really, in my mind, the way I was explaining it to the rest of our group, my understanding is if you can impart in your documentation in some efficient way everything that you normally discuss with the patient, and really show your thinking, and show that, you know, you're really trying to decide between surgery or not surgery, you may actually get value for that. Whereas before we didn't get value for that. We just, you know, ordered a test, and that was the beneficial aspect for our hospital system. So I don't know. I think it's definitely early. We don't even have any feedback yet on any of the recent billing in 2021. But it's interesting. It's a huge shift from what, you know, we're used to doing.
Yeah, it seems like we got away from, you know, documenting what we're doing to filling a piece of paper to make a EMR system happy that had been trained to get us every dollar that we can get, kind of scenario. So removing that and going to something else that effectively shows what we're doing without a waste of time is a great thing. I don't know if this is it, but I'm excited to see where it goes. I suspect it'll be like everything where they're going to try to control costs. They'll see which part balloons out and they'll go hammer at that.
I do like the idea that the time that we put in reviewing records, reviewing information. I mean, you know, if you see a hospital patient, you could spend 45 minutes looking through a month's worth of hospitalization information, and you don't get any credit unless if you've previously documented this, as opposed to now it's just more, you know, document which you important and necessary to communicate, and your time has a value to it. So I think that's a positive.
Yeah, and I think from my perspective, you know, that's some of the more significant shifts, especially as we think about the time that goes into it. Like, you know, before, as you all were mentioning, just now we can count time that we spent preparing to see the patient, you know, and coordinating care and all of those things, which before were just things that we did, but there wasn't any quote unquote credit that was associated with those things. Do you foresee yourselves changing, you know, like your templates and that sort of thing to reflect some of these changes, or do you think it's still too early to tell what are going to be the most effective changes workflow wise for you?
It's a good question because we've started to kind of implement different templates for different providers in our practice. Some were very happy to get rid of their review systems instantly. But I will say, I think some of them are turning that portion back on as they look to justify some of the complexities that may not come up in the specific wording of their subjective history. So as we all know, we look over all of those things and instantly put them all together with their little biases as we formulate a diagnosis, or at least a differential diagnosis list and plan. When we get audited, those review systems may be very helpful, where we glossed over and didn't write a or history as well as we would have intended to. So they're putting that back on, but I don't know. It'd be interesting to see, what are you guys doing?
I'm just including my thought processes into the impression and plan in a much deeper detail. And then obviously the time I put in counts. And then in the end, I just decide whether it's more important to bill for the complexity or the time.
Today, I saw a lady that literally took me an hour because she was so anxious about cervical lymphadenopathy, and I did the whole shebang and scoped her and, you know, did a full exam, looked at the old ultrasound, and, you know, I found it pretty easy documenting in the record that I looked at the old ultrasound. I called the doctor from the medical center and physically talked to them, put that in the note. I had to call her OBGYN because I put her on Biaxin and she's breastfeeding. So I put all that in the note, and I didn't have any problem justifying the time I spent with her and the complexity. And so I think we just have to be more cognizant about if we do it, put it in it and include it so we can get credit.
I am making a lot of smart phrase templates. So in the past, I feel like in all of my employment recently in the last 10 years, it's been Epic based. And I feel like the templates, to answer your question, Dr. Connolly, were much more interested in the H&P, the review of systems, the physical exam. And the assessment and plan section was often the blank part, right? And that was where I just wrote what we're going to do. But we did have a discussion with the folks that do our billing at the hospital. And, you know, I actually started writing smart phrases like for a CT scan of the sinuses or an MRI of the IACs. And it actually would behoove us to say there are risks of a CAT scan. We always talk about these things with the patient. If the CAT scan shows significant sinus disease and she has failed treatment, for example, then she likely will need surgery. We'll discuss that at the next visit. I have that as of the last 2 weeks templated for almost what I'm trying to do is every common condition. And now I'm going to be a lot less stressed, I think, about, you know, the H&P section and really thinking about, did I put enough things there? But I'm going to be much more interested in, even if we had an off the chance conversation about tinnitus, let me make sure that I wrote, there's no easy cure for it. The hearing's been normal. So I think changing the templates to really incorporate much more in the A&P, which almost used to be the way we approach the HPI, is really helpful. And I'm taking the tack that I'm less concerned about time and much more interested if I'm prescribing something or ordering something to really explain it. And then, as you said, Rob, you know, if I do review something, then that I'll type in because that's unusual and specific to that patient. So I don't know how that's going to play out. But we had our meeting with the coder and biller prior to making the templates, which I think was really helpful, even though at the time I did not want to do it in late December. So it might be helpful, Dr. Connolly, from your perspective to say, you know, what do we take out? Now, the one thing I have removed from my template are things that I never felt comfortable with. So in the past, in the physical exam, it would always ask you to list things. And I said, listen, I feel like sometimes I do a really focused exam and I only want to put what I actually did. And I see these people's notes as if they examined the entire body and listened to the lungs and listened to the heart. And I haven't used a stethoscope in years, really, for the most part, other than somebody with bad asthma or a suspected, you know, something postoperatively. So I've removed those from any of our templates within the practice because I keep telling our PAs and the other docs, it just doesn't feel good that we have them in the notes. And I feel good about that now because now we don't have that requirement for the elements in the RO review of systems, physical exam, and past history that honestly, we all sometimes never really did, but like you would see it in these templated notes. So I think it's a shift. I mean, I feel good about that part.
Yeah, personally, I'm hoping that it shifts away from some of just the nonsense that you were mentioning that gets auto-populated, and so that there's actually more meaningful information that's easier to find. And I think, you know, where I see a lot of that value is in, you know, underscoring the thought process that's going behind some of these decisions that are made. Because if you pick up, you know, a patient from one of your partners who's on vacation, et cetera, it's much more helpful to understand their thought process, you know, and why certain things were done than just to see like the template for, oh, this was a sinusitis, so here's the dot phrase for what we do to medically manage sinusitis from the get-go, when it's clear that there's something more, you know, going on with that patient.
I think our notes should focus more on risks. What are the risks involved in this particular medical condition? And that'll show more of our decision making. I don't think a lot of us are documenting the risk of missing something.
I think that's an excellent point. As I've been thinking through our templates, even the risks of medications that we give, prednisone being a prime example, heavily used in otolaryngology, mentioned to the patient all the time. And I realized it's not really in our notes. You know, there's a medicine I use often after surgery. Black box warnings on things like singular allergy, both testing and treatment, like the risk of anaphylaxis. Sure, we say it and we have maybe a one-liner, but I've expanded that to say there's risks to getting shots, and like, here's what we talked about. And just because you've had shots for 6 months doesn't mean that 7th month you might not have a problem. You always have to bring your EpiPen. Those are all things I feel like we converse with the patient, but I almost felt like I used to get fatigued by the end of the note and never really put that all in. So I don't know. It'll all, maybe we're being a little optimistic at the beginning, but I think it will be more meaningful. You can go to the end of my note and get a different plan for every patient.
I don't know how many of you guys do regular audits, but I wonder, being in private practice, I know the academic people get audited pretty often, but I wonder what the recommendation for our panel for the guys that are in private practice of how often they should at least have 10 charts audited, yearly, every couple years. What's your recommendation?
We do it yearly.
10 charts, 20 charts?
That's a good question. I don't really recall the number. It's definitely more than 10. I don't recall what it is. It's got to be a big enough to be able to go across different diseases, states, and different times of the year. We use Doctors Management as our company, not to give them any props, just saying that they have their own way of doing that to make sure, and they manage hospital systems as well as private practices. So I would rely on them to tell us what we need to do to stay out of trouble.
I think when I was in private practice, it might have been like 10 or 20, but it was also 10 or 20, maybe even every 6 months, and it was across the different providers, right? So even if it was like 10 or 20 charts, there were 5 docs, but I think you raise a good question, Dr. Stachler. I think yearly, if not biannually, is actually really helpful, because it used to feel when I first started in practice like, oh, like you don't want to answer their questions. But the reality is you also learn that you're under maximizing revenue for the practice, and that you're missing things, which in the past, for example, was the number of diagnoses. And depending on your training and whether you went from paper to EMR in different jobs, I feel like if you have the same company do it, or the same contact at the company, they start to understand ENT a little bit. I found that's been really helpful, that, it's a conversation that I'm now having every 6 months with the same lady, ideally. And I think for private practice, it's essential that, they give you somebody that can then do it again a year later or 6 months later, especially with the new changes.
They do a monthly kind of audit on your billing and what codes that you're doing, and how that compares against your peers in the nation and in your state, to make sure that you're not on one of the ends of the spectrum. They don't tell you, hey, you got to go do this, but they would advise don't be on the ends of the spectrum if you can't really justify that.
My private practice is managed by a management company in the background that does all the billing as well as collections. And so historically, they would audit each provider 10 charts a year to just make sure that it meets their billing standards. And then right now they're doing it monthly with the changes. And the important thing right now also is, with these changes, what's actually happening at the payer level. Are they actually paying? Are they going to come back and start auditing more charts to see, are we in compliance with the changes? That's the part that I don't know, and they're not sure about.
Yeah, and to you all's point, I think that it might be particularly helpful as things are changing, because I know that at least in my area, there's been a lot of excitement about the potential to essentially get credit for a lot of work that we've done all along, but we haven't been able to bill at a specific level. But then, human behavior is a funny thing. And if you're used to always billing a specific code for your perceived amount of effort or whatnot, even if now you can get credit for more, people might not be, claiming credit, or it might be hard to break some of those habits. So I think, as you mentioned, having having someone, give you the thumbs up that that's okay, and then also how that compares to some of your peers might be particularly helpful, especially if we're anticipating being able to bill a little bit more aggressively.
Have any of you encountered, my partner talks about this all the time, if you do otology in your practice and audiology, I will say that with the new changes, one of the shifts or changes in behavior is that in hospital systems or maybe in large practices, he sees patients with the audiologist. And I sometimes send patients for a hearing test, but it's not routine for me for every patient. He explained that if you order the audiogram the same day, you're the ordering provider, and then you're also the person reviewing it. Then in subsequent visits, you cannot be also then getting that credit for moderate or higher complexity for reviewing the same tests that you ordered, which in our hospital system, for some archaic reason, audiology was being billed under a provider, not as an independent provider, whereas previously in private practice, our audiologists would, bill the audiograms as they did them. So that's been a shift for us. And he was astute enough to really sit down and look at that and think about that, partially because our health system is productivity driven for a large portion of our salary. But the reality is those are not nuances that the billers or coders brought up or that, we read anywhere or heard anywhere. So I think depending on the specialty niche that you're in, even within otolaryngology, maybe the answer to your question, Dr. Stachler, is somebody coming in to audit with the new changes can start to help make you catch these missed opportunities, right? So I think that's where I would just keep doing, like you said, Jennifer, I would keep doing the same things unless somebody tells me to do something different. And so, I'm a creature of habit, and suddenly we're doing things a little bit differently when it comes to hearing tests. The good news is we're also not bound to be in the same location anymore. They can function as independent providers and be there on different days, and we don't need to oversee their work or see the patient that day after the hearing test. So it's making things a little easier in terms of flow of patients during COVID. But that's been a big change for us in the last 6 weeks or so.
Great. And then, just for anyone who's listening, the AAOA does have some resources available on the main website, and there's been some prior educational offerings that are specific for the CMS changes, and those go through the information in much more detail. We're not going to, recite the codes and how you time bill and all of that as part of this Zoomcast. But what I would be interested in hearing from the panelists here as we kind of wrap up is, if you could outline one change that you think everyone should be aware of because it's, it'll impact how you bill or how you document, what would that be for folks from your perspective? Keeping in mind that this is all relatively new and certainly there'll be more developments and best practices on the horizon.
Well, I'll use your example, Rob. So Dr. Stachler might have to think of something different. I think it's the risks. So there's certain things we do all the time, a routine prescription for a topical steroid spray, ordering a CAT scan. In my case, I never thought about putting the risks of either of those things, but I guess maybe the new way to think about it is not just what you perceive as the risk, but what the public and the patient perceives as the risk, because patients really think, radiology and radiographic imaging can be very scary, and suddenly putting that all in does the billing thing. And the second caveat to that, which has happened in our health system, and I think it's the law now, is simultaneous to the E&M coding changes, patients suddenly on Jan 1 could read their charts. So now it's really interesting because they're reading it because everyone's sitting at home with their little MyChart portal on their phone or whichever portal they use, and messaging me with questions. You mentioned this. So I guess in some ways, if they were reading their charts and I wasn't really now focusing on the plan, I would be getting a lot more questions around that front. And I'm sort of going back and saying, well, it's all there. What you're reading is exactly what we talked about. But I don't know if you all have encountered this yet, but I would imagine that the takeaway is whatever the patient thinks is risky, even if it's super routine for us, is free to go in there and can increase your billing levels.
It's interesting that you mentioned that you've gotten some blowback from patients when they read over their charts because they really don't understand what we're putting in our charts.
I would say my concern is with orders. So just adding on to that, records being immediately available to the patient. It's one thing when it's our plan because we've just hopefully appropriately expressed it to them. And if we haven't, then great that they can read it and go, oh my word, that's not what you said to me, or I totally heard something totally different, right? But when I'm ordering a lab, I'm ordering imaging, I'm ordering a pathology test to be done, I want adequate time to be able to address that. Instant response to that, I can see it from the patient's perspective that they don't want to be delayed a week or two for someone who didn't do it. But I think there should be a reasonable time frame for those providers to adequately set the table for those patients. I do think that there can be harm in this. And so all information is not necessarily good, but we'll see.
I like the idea of transparency overall. I think it forces us to perform at our best and try and document at our best. But at the same time, I agree with all of the panelists' concern. And then my takeaway from this is exactly what Dr. Khalid had said earlier. I think I'm going to set up templates for medications, templates for diagnosis in terms of differential diagnosis, as well as include in my plan as to the risk of no treatment or risk of conservative versus aggressive management. And I think it'll help the patients as they look at the chart understand the decision making and hopefully help them make better decisions too.
Yeah, and I think for me, what will probably have the biggest impact on how I bill going forward is just recognizing that all the tasks that previously were thankless and creditless, now we get some credit for them. So, all the pre-charting that we do, all the looking in the history, writing orders, and time spent documenting, those all, count towards some form of credit that can be leveraged as appropriate. And they are not just things that we do because we have to, which they are also, but... All right, well, any other closing thoughts from the panel here? Otherwise, we can conclude for the Zoomcast.
I think that the most important thing that we leave people with is that this is an ever evolving kind of situation, and we're going to be constantly changing the way we do things. And so be mobile, facile, and ninja-like when it comes to making these changes. And don't be afraid to ask for help and to get others' input. Talk to other doctors, see what they're doing, and get comfortable with the new terminology and read as much as you can and listen to as many seminars to get more acquainted with the changes.
All right, thanks everybody.
Thank you.
Thank you.